Good evening, good morning, good afternoon. We are global, like Corona. I love that. I'm going to say it every week for a while. Rose, I won't. Rose, I think this is like close to our 50th show. This is unbelievable, Rose. And I just love you as my sous chef and my co-host. Good morning there in Melbourne, Australia.
Hi, Tova. Thank you for the introduction. We've got David Schechter today. Thank you so much for coming on. Now, the reason that I want to promote a little bit about sports injury, and he is the go-to person in this area, as well as all the other normal TMS problems that people have. But in a way, I'd like to help people see that the sports injury is also a chronic problem. And Dr. Schechter spends, he can be spoken to online, he can have consultations online worldwide, and people who have given up their hobby or their interest because of the advice of resting the limb or resting the body is not the right advice for a person. And I'd like Dr. Schechter to give us a background first about how he became interested in the mind-body, because at university, the doctors actually don't get very much of that. It's all put down in what would you call it, silos. So it's not a silo that the medical profession actually looks at, unfortunately. And of course, it's the most important part of our humanness, is to see that the mind and the body are one, as Dr. Sarno said. And Dr. Schechter got his training from Dr. Sarno. So please, over to you, Dr. Schechter, and give us a bit of background about you and how you've developed it and how you've actually developed into that sports category, because it's so important. And so many of our viewers have been avid sports people and they've had to give it up. So over to you.
First of all, thank you for having me, Rose and Tova. It's truly amazing, the technology, to be live with someone from Melbourne and someone from Israel at the same time from Los Angeles. Pretty amazing. So I was a 21-year-old medical student, and my two biggest stress relievers and my two biggest hobbies were running and playing basketball. And I had just come off of winning an intramural basketball championship at college, and so I was gung-ho about basketball and playing. And medical school, first year, a lot of memorization, not really that pleasurable an experience, kind of grind it out. You're not seeing patients, you're just learning from the books. Very different from college, where I had a little more creativity and things in the work that I did. So I'm running, I'm playing basketball, I start getting knee pain. And it keeps getting worse, and I can't figure out how to make it better myself. So I do what a medical student should do. I go to the student health doctor. The student health doctor examines me, puts me on some anti-inflammatory medication, and the pain doesn't go away. So I go back to the student health doctor. He sends me to an orthopedic surgeon, very prestigious. He was taking care of the professional baseball team, the New York Yankees, when he wasn't seeing medical students occasionally for free. And he saw me, examined me, he recommended some exercises, and he did a scan. And they couldn't find anything seriously wrong with my knee, but I continued to have pain despite having strengthened my knee to the point that I was stronger than before, stronger than when I was playing basketball and running. So I didn't know what to do. I started to get worried about it. Would I be able to return to these passions, these activities that I enjoyed so much? I went to the library. I started reading up on knee pain, and I figured out that maybe my legs weren't as straight as they should be. I had torsion or twisting of the tibia, which is the lower leg. And you can sort of wind your mind around this. You can twist your mind into all kinds of patterns as you start researching. In those days in a library, now you do it on the internet. I caution my patients about internet research, because it can get you in trouble.
Dr. Google.
So I walk into Dr. John Sarno's office. He was a professor of rehabilitation medicine, and he'd given us a lecture.
How did you get referred to him? Can you tell us how you got referred to him?
I didn't get referred. He had lectured to us in anatomy as part of medical school, and I thought that he knew quite a bit about anatomy, so I figured he's a rehabilitation professor. I'd walk over to his office and I'd see if he could recommend some high-tech physical therapy. I did not realize he was interested in mind-body medicine, and he was not yet known as the guru of mind-body medicine. He had not written any of his books yet. This was the 80s. So I walked into his office and I told him a little bit about my history. And I said, is there some kind of physical therapy you could recommend? I've done all these exercises on my own. And he looks at me and he asks me a couple of quick questions. And he says, you've been having this for more than 3 months. It's already chronic. In my experience, son, and I was 21, so you could call me that. In my experience, 95% of this chronic pain is psychosomatic. What do you think of that? And it was like getting hit with a bucket of ice water. It was like getting hit with a blast of Arctic air. It was a shock to my system. And I kind of mumbled some words like migraine headaches can be caused by stress, but I'm having knee pain. I'm a basketball player.
Right.
And he goes, well, I see you're a little bit skeptical. That's all right. I have a seminar on Monday evenings that I give to my patients. I'm inviting you for free. And if you think it makes sense to you, if it seems right to you, then you can schedule an appointment with me and I'll confirm the diagnosis. And so I went to the seminar, curious, but skeptical. And I look around the room, there's 20 or 30 people. They're well-dressed, Upper East Side, Upper West Side New Yorkers, professionals in their 30s, 40s, and 50s, and me in the first row, 21-year-old medical student with his corduroy pants and a casual shirt. And he presents this presentation, and he lays out his schema of how the mind, the emotions can affect the body and cause pain. He lays out his schema of psychology with the unconscious, the conscious, all of this kind of stuff. And it made perfectly good sense to me. As so many people who've read his books or later my books and other books on the subject have said, it resonated. It just felt right. So I decided to make the appointment with him. He examined me, he confirmed the diagnosis. But even that first day after the seminar, going home to my apartment in Manhattan, an apartment that looked out on a brick wall. I could not afford very much at that time. My view was of a brick wall 3 feet away from my window. But sitting in my bed, I felt a weight lifting off of my shoulders. I literally felt the pressure of this worry, of no diagnosis, of no hope. I felt it washing away. And the next day I walked with a little more bounce in my step. After being diagnosed with him, I started shooting some free throws.
So nothing happened between sitting in your bed, the brick wall, and the next day?
No, nothing happened other than things were processing up here. Yeah. It was what I was cogitating, it was what I was thinking, it was what I was taking in and rewiring my brain. There was neuroplasticity going on, but there was nothing else going on. He had no formal program. He hadn't written a book. His program was a lecture series. So I started running a little bit. The pain was going away. I started playing a little basketball. The pain was gone. This was weeks, literally weeks. And I went to at that time he had a 3-seminar series. I went to the seminars and I told him afterwards, I said, you've cured my pain. You know, how can I get more involved in this? This is fascinating. I want to learn more about this. So we stayed in touch. And the summer after that summer, I was able to get a little grant and I did a research study in his office. I called up 175 patients that he had treated. And I kept hearing the same stories over and over again of pain that was unremitting or would not resolve with conventional treatments and alternative treatments. And they learn about TMS and they get better. I thought this is miraculous stuff. I shared it with medical students and doctors at my medical school, and they were skeptical. They were put offish. They were not interested. It didn't fit in their way of thinking about the body, the mind, the brain, whatever. There wasn't enough science behind it in their opinion at that time. And they figured I was just a kook. But I wasn't a kook. I was running, I was playing basketball, I was learning about the mind-body connection, and I was going through medical school. And I was back to sports, and I was able to guide some of the patients that I saw as a medical student to some of the emotional aspects of things. I continued in my training in family medicine on the West Coast of the United States, kept in touch with Dr. Sarno. I went on to sports medicine certification as well.
But I have a quick question. So you were in his office and you were making phone calls. You did this study. Is this study something we can see, or it's very old? The study was described in 2 of his books. We had a little bit of a conflict because he had told me we were going to publish the study in a journal,
but then ultimately he published it in his books, and that leads to a little bit of, a little bit of conflict, a little bit of tension in our relationship.
Right.
But,
Yeah.
that's not the subject
Well,
of today's talk.
I'm asking because you were in his office with him, and you just mentioned a little about that experience being with him.
So not only did I call the patients, but every patient he saw that summer, which was typically about 13 a week, I would be in on the consultation. So I sat in on every visit. I went to every seminar he gave on Monday night, the evening. I went to every one of those that summer.
Wow.
So I really had a comprehensive Sarno experience that really nobody else had at that point.
Exactly.
I was the first medical student or doctor who had learned from him, who had spent that much time with him, who had fully integrated and accepted this model for chronic pain. And yet he wasn't always the easiest fellow to get along with. That's not the subject of today's talk. But anyway, so I go on with my training, and I go on with my work, and I teach at a residency program in Los Angeles. Eventually I get into private practice, in addition to other work. And I'm seeing athletic people as well as ordinary individuals. And this is when I reconnected with him again. We saw each other on and off, but we're again continent apart.
I just want to make one quick point. Can you imagine being in his head? I mean, we see the movie, we see him, we see his pensiveness, we see his heart, we meet his wife, we meet his daughter. It's like, really, this is like.
Well, I know a lot about him, so I don't want to say that. I mean, I don't want to say me in his head, but I know a lot about him. Anyway, so we reconnect, and he says to me on a trip to New York, and he says to me, "Do you make this diagnosis of TMS?" And I go, "Yes, I do." I said, not everybody's open to it. He goes, that's for sure. He said, well, I've written now 2 books. I actually helped him edit his first book when I was a medical student, called Mind Over Back Pain. And my name is mentioned in the acknowledgments of that book. And I got a very honored spot. I think my spot is below his wife and above Howard Rusk, who is the father of rehabilitation medicine. So I got a very honored spot in the acknowledgments of his first book. His most famous book was Healing Back Pain, his second book, a bestseller, and then MindBody Prescription came after that, and eventually Divided Mind.
Right.
But he had written 2 books by the time we reconnected in the mid 90s or 94, 90, about, my private practice. And he said, I'm getting calls from Los Angeles. I don't have anybody to refer them to. There's very few people doing this. We could list them on one hand, and the fingers of one hand. And so I'd like to refer you some patients. So I gave him my card. I wasn't really expecting it very much because I'm in Los Angeles. He's in New York. That would be the equivalent of Perth and Sydney, I guess, in Australia.
Exactly. Yeah.
That would be the equivalent of United Arab Emirates and Haifa in the Middle East, because Israel's so small.
Very good.
But anyway, I suddenly start getting calls from patients, not only from Los Angeles, but from San Diego and Arizona and San Francisco. And they're desperate to see a doctor. And Dr. Sarno wouldn't see people from out of state. He wanted to see people in the New York tri-state area only at that time. So I begin to develop a really busy, or a really busier TMS practice. And I instituted an evening lecture like he did, try to model my work after his work. And this really gave me a large volume of patients to work with. I found a psychologist interested in this area, so I could have somebody to work with me on that aspect. And the work continued, seeing a lot of patients, helping people to get better. Eventually, I recorded my seminar, my evening seminar, because somebody couldn't make it one evening, and that recording.
I have them right here.
Yes, you do. That's the DVD version. I recorded
DVDs. My computer doesn't even have DVDs on it.
To show you how long I've been doing this, I recorded it on a cassette initially, a regular cassette, and I put that on the internet. So 1997 or so, I put up a website. It was the only website on TMS. It was an early website in the history of the internet, actually. And I put this cassette available for sale because maybe somebody's interested in it. And people started buying that. So I created another cassette and a third cassette with a psychologist, Don Dubin. So that suddenly we had a program that people could get in addition to Dr. Sarno's books that would educate them more about how to get better from TMS. His books were fantastic. They did not focus as much on treatment as my as my work did. So I tried to give people the treatment side, because he gave a lot of the theory side in such an eloquent fashion.
Yes.
So I had my cassettes, and eventually I did a video, which became a DVD, which became a streaming YouTube thing that's free now. So there's lots of stuff that I've done that I'm now giving away, which is fine, because I've written newer things like the Think Away Your Pain book and the MindBody workbook. The workbook was something that I wrote 20 years ago because people kept saying to me, so what do I do after I go home? And I realized that people needed something to reinforce the message and to help them to process emotions while they were learning about TMS. You see, the treatment for those who are not informed and are on this live session today or stream it later, Sarno would say to me, education is the penicillin. But not everybody gets better with penicillin. So education is an important element. The psychological aspect can be done with the initial office visits. There's an element to that with a doctor. There's an element in the journaling where you really learn about your feelings, you express them, you write about your anger, you write about your happiness, you write about your frustrations, get them on paper. Very beneficial. You can meet with an individual psychotherapist, you can work in group sessions. So there's a variety of different ways to do the emotional processing work, but there really wasn't anything available at that time other than Sarno's book. So my workbook was the first thing that really offered a treatment method, a method of journaling, which when I shared with Dr. Sarno, he said that he liked the fact that I was trying to become a little more systematic with the approach. He had been very loosey with how he did things, but obviously he had a very successful approach as well. And, I've treated now thousands of patients since the early 90s up until now. I've published a couple of outcome studies, the books that we talked about, and some other minor, smaller books and other items. And here we are talking about treatment. So, one of the areas that people have asked me about is sports and athletics, right? So I've had some interesting patients who were competitive college athletes. I've also seen people who were adolescent high school athletes, and they had pain. They had pain, but we applied the usual treatments, or they had tried the usual treatments, physical therapy, injections, X-rays, MRIs, but we couldn't really get them better. We couldn't find a clear cause. When you start probing and you talk to these people, you talk to these athletes, there's often other issues going on. So for example, the high school gymnast, often a woman, a girl, maybe she's tired of gymnastics. She may have been doing it since she was 5 years old, and she started it because it was fun and her parents encouraged her and she enjoyed it. But she got to be 13, 14. She had other interests in her life. Maybe she likes boys. Maybe she likes music. Maybe she likes biology. And gymnastics didn't have the same appeal. Well, how do you get out of gymnastics? Your parents have spent thousands of dollars training you over the last 10 years. You get an injury, you get pain, and it's a representation of your unhappiness, which if you communicate, you can then make a conscious decision to either quit, cut down your intensity, or perhaps decide to go on, but with a fresh perspective or a fresh coach or a fresh team. And so we see that in gymnastics. I had a college athlete from a major university who at one point thought he might make the Olympic team. And I think it was in decathlon, the athletic sport where you have 10 sports that you do, running and jumping and all of that. And he ran into some frustrations because he wasn't progressing. He had made just rapid progress in 1 year from, let's say, 17 to 18 or 18 to 19. But then he hit a wall. He hit a limit. His body just could not get better or faster, and he was not going to be an Olympic athlete. And for him, he'd rather do other things, but his coach was kind of pushing him and keep going. So there's always other issues. If you explore the issues with athletes, you find that there's more to them than just their bones and joints. There's more to them than just the ligaments and tendons. And that's really the essence of what Dr. Sarno taught me, is that, there's the mind, there's the emotions, there's the brain, obviously the body, and it all works together. And if we ignore part of it, we're not practicing good medicine, effective healthcare. And so then we're stuck in the and the logjam of chronic pain and chronic injuries and sports injuries and things that don't go away, that often could respond if you take a broader perspective on things. Yeah. So that's part of my message.
Yes. Do you remember a few years ago in the Olympic Games, there was a rower, and the team was out front winning, and she stopped rowing. Do you remember that? Seeing that?
I don't. Why did she stop?
Well, it was a psychosomatic problem, I'd imagine. I thought you might have seen it because it was just awful. It was terrible to watch it.
I'm sorry to hear that. Yeah, that is awful.
Yeah, and of course they lost.
You know,
she is winning, and then she gives up.
Many of the professional sports teams now employ a sport psychologist to work with their high performance athletes, because at the highest level of sports, and that's not the level that I participated in at all, but at the highest level of sports, the difference between winning and losing is as much mental as it is physical. They're all great athletes.
Wow.
If you're talking about a golfer missing a putt, if you're talking about a basketball player missing a free throw, a baseball player, swinging and missing or not making the right decision on the bases, it's more mental than physical. So sports psychology is very important at the highest levels. But what's not often understood is that athletes at many levels who have pain, who have an injury that doesn't heal in the usual time frame and manner that we would expect, may also be dealing with a mind-body condition. And of course, that's something that Tova and Rose and I can treat, can work with, can deal with, if the person is open to it.
How could any condition from A to Z not be helped and beneficial and benefit from a TMS model? How isn't there a slice of everybody's condition? Can you say that honestly? I mean,
well, I would say if you want to look at health and fitness and well-being in a broader perspective, then you can say that any condition should be approached in a holistic fashion with both mind and body. So, for example, in many of the major cancer centers in the United States, and I'm sure elsewhere, psychologists are employed to help people deal with the stresses of treatment. Now, that's not to say that they shouldn't get the treatment for cancer, whether it be surgery, chemotherapy, but there's also the psychological aspect of coping. There's the aspect of working on hope, or if you are not in a situation when you can be cured, of working on those issues emotionally. And
exactly.
Human life is just better if we're both aware of the psychological as well as the physical.
Mm-hmm.
But I don't say to patients that I can cure every problem with psychology. Like, for example, diabetes type 1, which is insulin deficient, I don't know of any way to cure that with psychology. Type 2 diabetes, which is often related to your weight, as well as your intake and your stress.
Mm-hmm.
There's people who get quite a bit better by incorporating a holistic approach, which might include exercise, losing weight, stress management, etc.
Mm-hmm.
And under their doctor's supervision might be able to reduce their medication or even get off their medication. With blood pressure, I don't tell people that I'm going to cure everybody with blood pressure by a TMS or a stress management approach, but many people with blood pressure need to get more active, eat better, manage their stress. And with a combination of those things, some people never have to go on medication, and some people can get off of their medication or at least reduce their medication.
Mm-hmm.
So I'm just mentioning a few chronic conditions for which both emotions and the physical medication or surgical or other treatments are appropriate. The thing about TMS that's so powerful is we're not saying you can get it a little better. We're really saying with TMS, you're doing it the wrong way if you think you're going to get better just with a physical approach. You actually have to switch really more the opposite direction, which is more of the mind-body educational psychological approach if you want to get better from a TMS condition. And we can list some of those major conditions. I've just mentioned it before: neck pain, back pain, migraine headaches, tension headaches, irritable bowel, some of the so-called overuse conditions of the extremities, arms, legs. Some of the plantar fasciitis can be TMS as well. So, there's a lot of conditions that can be TMS, but, it does take a little bit of medical expertise and discretion to figure out who benefits from primarily psychological, who benefits from an integrative approach, and who needs, primarily a physical or chemical or structural approach.
Yeah. Would you elaborate a little bit in regard to this medical background about self-esteem? Because as I've been listening to you, I've been thinking it's really about self-esteem when the patient understands that they've got a lower self-esteem, or I don't know how you describe it, then the physical problems remain there. And until they actually realize and have that ability to self-reflect and see how they've negated their own feelings, I suppose, then the pain persists. And I thought of all those people and all those athletes that, and, you were talking about the gymnast and that, and I thought, she hasn't got the courage to tell mother and father that things aren't going well for her. So she becomes ill or has knee pain or whatever. And I thought it's the basic underneath part about it is about having a poor self-image, way of describing who she is to other people. Could you sort of
that's a very insightful comment. The early literature on TMS, which was written by Dr. Sarno and some associates in psychiatry in New York, focused a lot on anger and focused a lot on rage. And I really was one of the people that helped expand the thinking on what emotional issues are involved, including grief, anxiety, fear, etc. But a therapist that I worked with, Donald Dubin, who is deceased, he really came up with the self-esteem idea about almost 20 years ago. And he really focused with patients on self-esteem issues, as you've brought up now as well. And he said that his approach was to get people to accept who they were. He called it accept and surrender, but it doesn't mean surrender to the condition or surrender to the failure. It's more of surrendering to the idea that you have TMS and that you're going to have to work through that. But low self-esteem is definitely one of the personality factors or issues that contribute. So I absolutely agree with you on that. We talk about a type T personality. Type T personality is typically a person who's very hard on themselves. You could say self-critical, highly responsible, usually for others, can be a goodist, which is someone who wants to fix the world and puts a lot of pressure on themselves to do that. Sometimes a perfectionist as well. And so there's a number of these personality characteristics that go into the type T personality. I wouldn't say that everyone that I see has low self-esteem, but that's something that needs to be explored when they're in therapy and they're having chronic pain issues, just as you mentioned.
Yeah.
Well, usually a driven person, for someone who's driven, behind that is I'm not good enough, so I'm going to drive myself.
Mm-hmm. And sometimes that comes perhaps innately from the person's personality. Sometimes it comes from the way they were raised, trying to overcome either a impoverished background or a impoverished in a different sense background, emotionally impoverished.
Emotionally impoverished.
And attachment issues and parents who were not there emotionally for them, or certainly other challenges that kids run into in terms of the early divorce and other things. And we do have some people with chronic pain who have more dramatically difficult childhoods, including abuse, both psychological and physical, sexual. That can certainly contribute to some very severe cases of chronic pain and other conditions.
Rose has turned a lot of our listeners and a lot of our patients and clients onto ACEs, which I didn't know about. I mean,
adverse childhood experiences. So,
Rose has taught me a lot about that.
Yeah, it's a great and important concept. And Dave Clark, who's one of the TMS thinkers in the United States, talks a lot about that. But one does find that it tends to be alcohol in the family. It tends to be divorce. It tends to be emotional impoverishment. And these things are adverse childhood experiences on the list, which, but you know, it's, to me, I just don't want to make it a scoring thing. I'm trying to understand the person and what drives them and their makeup and things like that. So it's good to have that adverse childhood scale, but it's really about what the particular person has dealt with and affects their makeup today.
Yeah. Could I just add a little bit about
Sure.
what Dr. Schechter has said, and to remind our viewers and our listeners that what we're really talking about is love. And we're talking about attachment in a way of showing other people that we are lovable and that we love. Mm-hmm. And underneath all those other self-esteem issues, and that is looking for love or trying to show love. So just keep that in the back of your minds, that it's not about the anger, it's about the love. It's not about the grief, it's about the love. It's not about the sadness, it's about the love that's underneath all of that. So when we talk about anger and those sort of issues, we're actually talking about our love not being recognized. And if we can go that direction, we then don't need to see anger as being a bad thing. Anger is about wanting to be recognized and wanting to be loved and wanting to show our love. I just want to add that extra little bit, because clinically we don't really talk about that. And I suppose from an ISTDP perspective, that's where we come from, that it's always about peeling back the onion, and in the middle of that onion is a love heart. And that's what we're exposing. And that's what Dr. Schechter is actually taking us through. As he talks, he's taking us through the fact that underneath that, we're made for love, and that's all we're made for. So I just want to add that extra little bit.
That's a powerful message, Rose. I'm glad you shared that. I see there's a question on the screen. Is that something that did you put up there, Tova? Or how did that get?
So yeah, that's how this Be Live works. First of all, before we answer Colette's, I want to add to that, Rose, is that, you know, remember the doctor who would come and pat yourself and put a warm rag on it. I mean, think about the doctors of the yesterday, and where he'd go in his backyard and get an herb from the garden, you know. So you doctors, it's, you know, Rose and I we're looking for a doctor to talk to us about the stress of being a doctor.
That's right. Yes, I've explored that, and I haven't had any success. I actually found a book that a doctor wrote here in Melbourne, but she hasn't responded to my emails. Yeah. So I wonder if the stress has got to her so much that she's given up medicine. I mean,
Dr. Schechter, it's not easy to be a doctor. And like, I remember when I got out of chiropractic school, I had to go to therapy because I didn't want to say no to a patient. I didn't want to ever say no to a patient, as if I was God, like I couldn't say no. So and Colette asked, we can move to this question. Do you ever have TMS flare-ups yourself, and how do you address them?
On the question of stress as a doctor, I think that should be a separate conversation, a separate discussion.
A show.
People have their own problems. They don't want to worry. They don't want to necessarily worry about a doctor's problems, I think. But it's interesting. A lot of my patients do say, "How are you doing, doc?" And so they do show an interest, especially after they get to know you for a while, interest in what you're doing in your life. But how much to reveal is interesting, because you're looking to be friendly, but you're not necessarily looking to be friends, right? You're looking to have a professional relationship rather than an intimate personal relationship. So that's a subject that maybe offline Rose and I can discuss with Tova.
Well,
on the issue of flare-ups. So here, there's several aspects to that question that I think are very important. One is, let's say you get over TMS, as I got over my knee and knee pain with Dr. Sarno all those years ago. Does that mean you're cured for good? And unfortunately, if you've read some of Dr. Sarno's books or any of his books, and I blame this on the New York editors that edited it. They're big publishing companies, right? So they're editing it in a way to create a story that they think will sell or impress. And so I don't think he could convey, in a sense, the fact that this can be an issue that comes back for people, because we're human beings, right? We have a certain personality, we learn about it, we get better, and it can come back. So that's not unusual for it to come back. But you're better at dealing with it the second time or the third time. You're better at it as long as you're open to the mind-body connection. Sometimes you can get tricked because it's a different part of your body and you're not thinking about mind-body or TMS at that point. So that's an important aspect of that question. And then another aspect of that question, before I get to the real essence of the question, the other aspect of that question is people always ask me, so I'm done with my pain's better. I did the workbook. Should I keep journaling? So I tell people, well, it's actually a good thing to keep journaling, even if you don't do it every day. Maybe you do it a couple times a week. It's certainly very psychologically healthful, effective. Many people enjoy it, some don't. But the reality is that when we feel better, we tend to stop doing the treatment that got us better because we're kind of moving on with our life. We're just, we're working, we're dealing with our family, we're seeking love, we're doing the other things that Rose and Tova are talking about. So people often drift away from doing the things. So people say to me often, like, do you journal every day? I don't journal every day, but I do journal sometimes. And what I do try to do probably more often than most people is try to check in on my emotions. You know, how am I feeling? What's going on right now? Now, I don't always succeed with it. I don't always find the answer, but it's that doing that check-in is a good thing, right? And that's something we talk about in my healing group as well. The psychologist emphasizes to people that concept of checking in with yourself. Okay, so now that we've discussed what I do, what I haven't done, and what I didn't do I get TMS symptoms? I have had TMS symptoms. I mean, I've even had fake coronavirus a couple of times because this has been a stressful 10 or 11 months, right? It's been a stressful 10 or 11 months for patients, for citizens, for people in all the countries of the world, with the possible exception of New Zealand, who's blocked their borders and doesn't have any cases. But it's been very stressful. It's stressful for physicians. And I'm not even at the ultimate front line, which is emergency rooms and first responders, but I'm in an office. I'm wearing a mat when people do come in to see me in the office, and I do a lot of telehealth right now, so I'm not bringing that many people in. But when they do come in, I'm wearing a mask, I'm wearing a shield, and it's not natural. It's not what we've been doing for my whole career. I'm not shaking hands with people. I'm not. It's just, you know, you keep a distance instead of close. You get close when you have to examine, then you step back. It's awkward. So, you know, you worry about this coronavirus, right? Especially if you're over 40 or 50, I mean, the risk is higher than it is for very young people. So I've had symptoms a few times where I have to go get a swab. Example of a stress-related condition. I know it's from the ongoing pressure of this epidemic. Now, the fact that I had my first vaccination a couple of weeks ago, I'm getting my second one on Friday. I think this will continue to lower my anxiety about this condition, because although I'll continue to use protection as is recommended, I should be at much lower risk of either picking up coronavirus or getting a very severe case. And that's why I would encourage people to get the vaccine around the world, to protect yourself and to protect others as well. Even if you're not a vulnerable population, you know, you could be protecting other people who are vulnerable. So think about that. I've had other TMS conditions over the years as well, but I've been able to notice them, recognize them, and have them get better. And sometimes that takes a test. You know, I mean, some of my patients will go to me, you know, geez, my back is killing me. It's probably TMS, but can you just get an MRI on me so I make sure it's okay? And of course, I start by examining them first and trying to determine if it's appropriate to get an MRI. And some of them I say, you don't really need an MRI. You don't have anything that's going to show up. And they go, listen, it's just my anxiety is really high on this. I'm starting to worry. I'll even just go to a facility. And in the United States, you can either use your insurance if it's medically appropriate, or you can pay cash for it if it's something you're just doing as your own reason, but it's not medically appropriate. And so, you know, there's a lot of MRI facilities in the US compared to other countries. So people can go and pay a few $100s, get an MRI. And I found that as soon as that MRI comes back normal, I call them up and the pain is gone. And they call me the next day, I'm fine. And now that didn't show a lot of psychological awareness and things, but it was anxiety that had built up, and the results helped in the short term to lower the anxiety. And I would still encourage them to look deeper and to journal and to try to understand what might have been the trigger for the anxiety. But so I've had TMS I've gotten better. It can come back, but it doesn't come back in the same disabling, crippling way. Typically, it comes back and it tricks you in other ways, you know, fake viruses and other things that you get. And the psychologist that I work with on this group together, you know, he had a number of years of TMS before he got into grad school. He did his dissertation on TMS, and he still gets a symptom from time to time. But you know, again, it's controllable. It's the human existence. It's more about experiencing life as a human than it is about having a disease. And so for those of you who are really suffering from long-term symptoms that haven't gone away, you need to delve in and really get the treatment for TMS and a diagnosis. For those of you who have gotten over it and, you know, have more relatively milder things and stuff like that, I guess that's part of the human condition. You just need to continue to grow and learn and check in and do the things that we do to be healthy, and accept our flaws, accept our ups and downs, accept our type T personalities, and work within that. So that's my message. I'll see if Rose and Tova agree or disagree.
Well, that's the basic message, isn't it? Really, and also that the world is safe, even if it's not. That we're safe within whatever comes up. We're safe.
That's a very important message. You know, I use a lot of affirmations in my work, and I talk about affirmations with you if you want. But one of the key ones is exactly what you said. I'm healthy, I'm strong, I'm safe.
Yeah.
And you have to sometimes say that even if you don't believe it. And we start to believe it more when we say it.
It's called the law of attraction, the law of attraction.
But also, look at it another way. When you say, I'm safe, and then your punitive superego says, no, you're not, you can then disagree with your punitive superego, can't you?
Yes.
So it moves you in a different direction.
Right. You can have that conversation. You can soothe that child within.
Yeah.
You can have a external conversation with yourself, which there's some research on lately. That's a very powerful way to do self-talk, is to talk to yourself kind of in the third person to yourself. Yeah. You don't have to do it out loud.
Well, you have a cup of tea with your little child. You have some coffee with your little child. Yeah,
you say, hey, Dave, you know, you just got to chill out about this. It's not a big deal. You're going to be fine. And that type of third person self-conversation is another healing technique that can be used.
Yeah.
Excellent.
Yeah. Exactly. Yeah. And realizing that you know, that voice or that inner what would you call it, feeling about being unsafe is about previously being unsafe. And yet as an adult you are safe, and you can create your own safety or whatever. You know, if you like wearing a mask, it provides a certain amount of safety. When you're working clinically, you know, wearing the mask and the visor, you've done your protection. So as long as you do that and you're washing your hands, you know that you're not taking the virus on. And if you're not touching your face, you know that you're not inhaling, because the virus on your skin won't do you any harm. It's a virus that goes into your system that does harm, that goes into your respiratory system. Yeah. Because it's a pneumonia type.
Right. You have to. I mean, if you touch yourself, if you have a mask on, it's hard to touch your face, but you have to touch your nose or your mouth or your eyes.
Exactly.
To get it in, or you have to breathe it in. And so, I mean, as a physician, I take certain safety precautions, and I do more. Even with people in the office, I might have a brief phone call with them 20 feet away from different rooms before we get into the face-to-face consultation, just to limit the time that we're together. It makes them safer, makes me safer. Yeah. And the broader issue, as an adult, even if you have something in your life, and that could be heart disease, cancer, diabetes, you kind of can remind yourself there's people that can take care of me with this. So that can be a very reassuring message for adults, which is, even if I have something, there's people that can take care of this for me or with me. Yeah. And so that can be reassuring. There's people who can do heart treatment. There's people who can do eye treatment. There's people who can do diabetes treatment. There's people who can do psychological treatment, chiropractic treatment. There's various types of things that are available to make me feel better
Right.
as an adult if I can't solve it myself. So that's a reassuring message as well.
So,
It is.
Dr.
Yes.
Schechter, a lot of times Rose and I separately or together, we get patients that really have seen a lot of different people, have read the books, have done a lot of journaling, have done a lot of meditating. And, when they come to us, because I like to think positive and think that, what Rose and I are doing is something very unique, and we have a lot of experience, and we're very maternal in a way, and yet tough love. I mean, Rose can be very tough. Rose can be very scary.
I can see
I'm never tough.
Rose can be, but the question I'm getting at is that, I'll say to people, I'm not guaranteed. First of all, I don't use the word cure. It's a journey. It's a process. It's about, it's not a beginning, end, or middle. It's more like I don't even like to use the word control, but the more important thing I want to ask you is that these people, that it becomes that they're just so cerebral, I call it, in their head. And we teach them about getting into their heart and accepting. And it's almost just like some people just like they can do it. And there's some people that just go on and on and on and keep thinking there's one more thing out there. There's one more thing out there. And then I feel like it failed. I didn't fail. Like, I don't want it to fail. I want them to get it. But I can't teach them if they're not ready. So what I'm saying is there are people that it's very difficult for them to figure out, what their particular journey is. And then they're going to one more therapist, and then it's almost like it failed, the interaction between us and them, or they didn't get the TMS, or they're doubting their diagnosis. So you must have had people, you and your psychotherapist, that just, what do you do with that? Don't you feel like you want to help them one last time and figure it out?
Well, I think a couple of things come to mind. One is people need to hear from their doctor that this is the correct diagnosis. So anything you can do to create evidence for them that TMS is the correct diagnosis is very important. That would be reviewing MRI reports, or if you have training in reviewing MRI scans or lab work or whatever. The point is, you have to really believe and accept this as your diagnosis. This was a key stage in getting better, that you have to, I think you accept it intellectually and you accept it emotionally. And I talk about the 12 stages of healing in my book, and those are 2 of the stages. But Sarno emphasized to me, they've got to accept the diagnosis.
He said that. You have to 100% accept psychological.
Focus on that. Focus on what evidence they're using in their own minds that it's not TMS, and you have to dispute that. You have to do a disputation like they did in the Middle Ages or whatever, when they argued about things. The second thing would be that there are people, like you mentioned, who can intellectually get the diagnosis or get the treatment, but they're not getting to the feeling state. So we talked about in the group last night that I do, we talked about feeling and dealing. And there's this concept of, I guess, the window of tolerance, where you can be in different sections of that window, different panes, PANE, of that window. And you've got to make sure you're in the right balance between feeling and dealing. So dealing is action, and feeling is obviously what it says, emotion and feeling. And so working with people sometimes to not just be intellectual about it, but to really be conscious of their feelings can be very important. So I think accepting a diagnosis, number one, and then thinking psychologically, which was number 2 that Sarno emphasized to me. And that comes along with feeling rather than just thinking. Thinking psychologically implies thinking about feelings, but you have to feel. And there's some people who are great at intellectualizing the answers to the problem, but they're not really sinking into the feeling level. Rose mentioned love before, the love part. You have to get them into that emotional level. And for some people, it's harder. So it takes longer.
Could I add to Dr. Schechter's point, and that many of us have had difficult early attachment problems. So when we've had an attachment problem, like we've had a parent or a mother that had mental illness or different things, well, then we've got a problem connecting with the doctor or with the person that's telling us this. And that acceptance business, or that acceptance model that Dr. Sarno is talking about, is actually about accepting yourself in a way. Accepting the diagnosis, yes, that's theoretical, but accepting yourself internally. And that's where the self-esteem model comes in. And when you've had a broken attachment, you're going to find that area quite difficult. And I suppose my midwifery background sort of,
Well,
Rose, I love your psychological insights. I look forward to referring some patients to you in Australia.
Well, Rose taught me, Dr. Schechter, I just want to say, Rose taught me a lot. I mean, when I met Rose and I got together with the help of Michael Galinsky, we met and we started the show. And, I didn't realize myself some of the ongoing TMS that might happen is because of, people, it's very hard for people to let go of their trauma. They kind of need their trauma. One of our patients said that the trauma is the last thing they're willing to let go of. And we see that these are the people that are struggling still. They're just like, there's something, they cannot accept 100%. They know it's not physical, but it's like they're stuck in the cage with the door open.
I had one patient say, and he said this on the TMS, I call it the MindBody patient panel, which is on YouTube now. It used to be a DVD that I sold, and what he said was pain had become his like a friend. Yeah. That's a very strange concept when you first hear it. But what he was saying is that there was a relationship that his entity, that his inside had with pain, that at some level provided something for him. You wouldn't say it provided comfort, but it provided something. Maybe Rose can explain that in psychodynamically to us in a moment. But that has to be broken, right? A person has to want to go on with their life stronger than they want to be stuck in their patterns that have created some level of comfort for them. And that's sort of another way of saying if you're not ready to change, you're not ready to get better, we can't help you.
Exactly.
That's not a criticism of you. That's just an understanding of where you have to be in order to go through a change process.
Yeah. Well, clinically we call it secondary gain, but you don't say that out loud to a patient.
Yeah.
But you ask them what the advantages are of holding on to that pain. And of course, in actual fact, you're holding on to the pain because the pain in your heart is greater. The pain in the heart is more deep and more scarring than the physical pain.
I'm making note of that. That's so powerful. I got to write that down.
Go Rose. Go Rose. Go Rose.
No, you're absolutely right. I mean, but it goes beyond secondary gain, which is a concept from behavioral psychology that neither Sarno liked nor I particularly love. But it goes beyond that to this idea of almost like a relationship with this pain. It becomes something. Now it's a fight. It's a fighting relationship. But people stay married for 30 years fighting too. So obviously there can be fighting in a relationship, but it's a fighting. But there's still something there. And so sometimes people who have attachment issues or have relationship issues, the pain becomes almost a substitute for human interaction and also a way to avoid it. It's a substitute and an avoidance at the same time.
It's defense.
Yeah. Yeah. Well, it is primarily it's an avoidance, isn't it?
Yeah.
It's an avoidance of your deeper issues because your pain, you can explain to people, I can't go to that event because my back is too painful.
Right.
I can't do this because my back is too painful. I'm using that as an example.
Yeah.
They don't sort of see that, that the issue is that they're going to feel another problem come up when they go to that event.
Yeah.
Whether it's, sense of isolation or heaps of various things. So it's easier to make an explanation that, I constantly have this back pain that I can't get out of bed. And that way you don't have to deal with your issues. Yeah.
Well, we're here talking about the fact that to get better from chronic pain and other related conditions, what you have to do is go inside a little bit and explore and express and understand and connect. And that's it's a hopeful message. It's not a criticism of a person at all. Many of us in this round table have had TMS. I can speak for myself personally.
Yeah, we can all.
We can all. Okay, I didn't want to assume anything, but it's not a criticism of anybody. It's just saying that this, if you want out of this path, if you want out of this problem, there's a pathway. Yeah. And what we can do as practitioners is guide you on that pathway, but ultimately you have to be willing to walk the walk on that pathway of healing.
And like this is where, I don't call it CBT, but I do talk a lot about that. None of us learn to feel. As a child, we learn to brush our teeth every day, and I don't think twice about brushing my teeth. It is automatic. Okay, so
because you had a punitive parent that made you do it.
I can learn to be mindful of what I'm feeling. I can learn to witness myself reacting. I can learn to respond to something and feel the calmness of I can learn to be in touch with when my chest feels tight because, so I think this is a learned thing that really what we're doing. And that's what therapy is. That's what, reading is. That's what journaling is. I'm learning a skill that I kind of wish our kids in school were learning. They would teach this.
Well, that transitions into something that I don't know if you're aware of, but I've been working on a curriculum for middle school and high school to teach MindBody in the health education. And I've written a workbook for teenagers for that purpose. It's been reviewed by child psychologists.
Amazing. It's excellent.
And so I've got an assistant now, a volunteer who's going to be helping me with the project. So I'm hoping I can take it further, but we're working on piloting it in a few schools, getting feedback, improving it, and then expanding its availability. And I just think it'll be so great to prevent the epidemic of mind-body disorders rather than just treat it by making younger people aware of how important their feelings are, not just for their emotional health, but for their physical health. It's called social emotional learning in schools in the United States, and it's something that's gradually growing, but there's a huge need for it.
Beautiful.
We have worldwide epidemics of teenage suicide. We have drug use. We have vaping. And many of these are people who are not learning how to deal with their feelings and their conflicts and their relationships and things as a young person. So I'm hoping that a little bit we could contribute to that with this high school curriculum or middle school curriculum. And then the teen workbook plays a role in that. So that's something that I'm working on.
Great. Beautiful.
Fantastic. Could I take us back a moment? Sorry to move away, but I want to move back to our primary reason for being here. And that is that we need to talk a little bit about fear and fear of change, fear of our feelings, I suppose. And when you were talking earlier on, Dr. Schechter, I was reminded of facing your fear. And you were saying about, you need to be in a space to actually hear what's going on. And what came to my mind, and I don't know if it's the same in America, but I notice here with the football, the players run out and they run through a screen and they break through to the other side. And that's what we need to do when we have chronic pain. We've got to face that chronic pain and break through it, not run away from it, just go for it. And can you just sort of talk a little bit, because when you'd be dealing with patients all the time, that's one of the subjects you'd be bringing up, I'd imagine. Can you just expand a little bit more? I know we've run over our hour already, but have you got the time to?
I've got a few minutes. There's a term called kinesiophobia. So it's fear of movement. Mm-hmm. And I see it a lot in people who are convinced that if they move, they're going to hurt. And if they move, they're going to damage themselves.
Exactly.
I love that.
Have them bend over in the office, touch your toes. I can see them moving robotically. They're frayed, they're tight. As they learn about TMS, they learn to move more fluidly. They just naturally start letting go. But you're talking about fear of movement. You're talking about breaking through. You talk now. A lot of them are saying to me, "How active should I be?" I say, "You got to be more active than you are now. What is it you haven't done?" I haven't hit a tennis ball in 3 years. Okay, well, maybe we'll start with that. You know, hit a ball against a wall a few times instead of playing a game. Then we'll expand to rallying with someone from the baseline or something. So we definitely work on getting people more physically active to deal with that fear, which medical word kinesiophobia, to deal with that fear of movement that is so prevalent in people with chronic pain. So
thank you. Oh my God, you have touched very, very deeply about fear in another way, because, you know, we often think about fear mentally or theoretically, but it's actually fear of movement, isn't it?
Yeah, it's fear of
movement. Of course,
leads to movement. Like I'll say to somebody, "Why are you stopping there? And does it hurt?" "No, it doesn't hurt yet, but I'm afraid it's going to hurt." So if they're not stopping because of a limitation, they're stopping because of an emotion and a thought that it's going to hurt. And I have to help them break that cycle. And that's how they get better, because I say to them, just let gravity take you a little farther. You don't have to push at all.
Just come to you and they say, but they're other doctors. See, Rose and I, we're not against doctors. We very much are about integrating doctors, medicine, and emotions. But there are a lot of doctors who will just outright say, they're very restrictive. Don't do this, don't do this, don't this. So you have to say, well, I'm telling you it's safe.
Right. I saw somebody in the chat wrote, "Chronic pain is an epidemic of fear." So I like that phrase.
Yes.
And it's an epidemic perpetuated by, I'll mention some people. I don't want to insult anybody, but it's perpetuated by the media. It's perpetuated by some of the healthcare system, you know, and I'm talking about some physical therapists, and I love physical therapists, and I refer to them for sports injuries all the time, but some chiropractors,
of course,
you know, will tell people, don't move, don't do that, come back for an adjustment, but don't do anything in the meantime. Well, how are you going to live if you don't do anything?
Right.
Sarno's big insight decades ago was, with back pain, get people up and moving.
Right.
He said, I don't care how bad it is, move a little bit.
Go back to your normal exercise.
If you can believe it, that was at a time in the United States where some of the people with severe back pain were put in the hospital and put at traction, which is immobilizing you. It's stretching you, but it's immobilizing you. First of all, now you can't even get in the hospital unless you're one step next to death. And I'm not talking about COVID. I'm talking about even before that, because of financial reasons. But certainly you're not going in there for back pain for attraction. But what happened is, then there was a study published in the New England Journal of Medicine that said that nobody should have more than 3 days of bed rest for any kind of back pain. Now, that was at a time where doctors would put people to bed rest for 2 weeks. So this was a huge progress.
Right.
But Sarno was telling people, don't go to bed at all for back pain. If you're going to go to bed to sleep, but got to keep moving. Got to keep moving, right? And so that study helped to corroborate, as so much science, and we haven't gotten to the science today because we've talked a lot about the emotions and the psychology, but there's been a lot of science in the last 30 years that has corroborated the original hypotheses that Sarno wrote, albeit he wrote them in a very Freudian way or a very observational way at that time. And in my book, Think Away Your Pain, does relate to some of that scientific research in a jargon-free way to explain to you that the advances have really supported this approach, not a immobilization / surgical approach for most people with chronic back pain, let's say, and other things.
Yes. Excellent. Excellent. Well,
thank you.
More questions from anyone. There's been a lot of, what happens is people start getting in conversations with each other, and we have a little.
I have to do this again. Then we can.
Really? Will you be a regular? You want to be a co-host sometimes with Rose and all?
I don't know. We'll talk offline.
No,
but
I'm so excited. I really appreciate your time. You know, Dr. Clark's coming on next month. We had Dr. Schrubener. I am so grateful. Rose and I are so grateful because you care. You care enough to give an hour of your day to educate. And I know you're busy, but it's just devotion to the cause. And I'm just in awe, and really, 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 I'm very grateful.
Thank you.
Colette's got a question before we go. Where's Colette's question?
Thank you for having me. It was nice to meet you, Rose, and to meet you visually.
Yes.
So,
yes. I let me see real quick. There was one question. Where was Khalid's question? Rose is very scary. That wasn't it. No. Whoa. I don't have it. Yes, she answered the one about flare-ups. He answered the one about flare-ups. Anyway, listen, they can send it to us, and we'll get the answer from you, because I'm very appreciating when I email you that you email me back. Really, I mean, you have 2 sons and a wife. One wife. That's amazing. And
where did that come from?
I know, because Dr. David and I have a comical relationship.
Oh my God! All right. Okay.
What does she ask?
It was great being on the show. Great being on the show, and definitely have me back again if you have more questions or issues.
Well, thank you so much.
Thanks, David. Thank you very, very much.
Take good care. Bye-bye.
I'm really appreciative of you. Okay.
Okay, wait, it's going to go off in a minute. Hold on. Here we go.